UMD, and we're all classmates, all bio majors, pre-med. So we've known each other from classes and stuff.
That's awesome.
We all go to University of Maryland, but some of us are from New Jersey, New York,
UMD,
and Maryland. Yeah.
All bio majors, pre-med. So. All right, guys, we are live. Classes and stuff. So make sure
we all go to University of Maryland, but some of us are from New Jersey.
Mute yourself if you haven't already. So we're going to take a little bit for people to come in, but just going to do a couple announcements and introduce our physician. Hey casters, welcome to today's session. If you're new here, the session proceeds as following. We have a presentation given by our presenting physician, followed by a Q&A. So make sure to drop any questions you have in the chat throughout. Afterwards, we will release a quiz/journal entry. Please take your time and fill those questions out carefully, because this is a way for you to reflect on your session and get the most out of it. Also, make sure to join our email listserv. You can sign up on our website. We'll drop that link in there too. Make sure to come out to our next session, Thursday at 5 p.m. With Dr. Fredericks. It was moved from 7 p.m. to 5. So make sure to update your calendars. Now it's time to introduce our presenting physician, Dr. Lalani. Dr. Lalani works in internal medicine and is a hospitalist with a focus on palliative and hospice care. She completed her fellowship at NYU in palliative care and hospice care after completing a residency in the internal medicine with the New York City Health and Hospitals. She attended Touro College Medical School in New York City. And more recently, Dr. Lalani has traveled to Texas to help treat a surge of COVID-19 cases with a limited supply of physicians. Dr. Lalani has a tremendous array of experiences in the medical field, and we're so excited to hear from her. She also has a very fun Instagram account with a lot of educational videos. I highly recommend you check it out. She's tagged in our post, and we'll also drop the ad to that as well. So without further ado, whenever you're ready, Dr. Lalani, you can start.
Hello, I'm so excited to be here. So my name is Dr. Shelley Lalani. I am a board certified internal medicine hospitalist physician, and my specialty is palliative care and hospice. So today I just want to walk through and give you a brief introduction of what an internal medicine hospitalist does. And more specifically, I'm going to focus on what palliative care and hospice is. It's a very important field of medicine that is not talked about enough. And I want it to be a very educational and informative session. So what I'm going to be doing is I'm going to present you a case. So it's going to be like an actual shadowing session when, med students or residents or fellows, whenever they shadow me, what we usually do is, we discuss a case or we see a patient in person. And so we're going to walk through the case, and then I'm just going to talk about, what I'll be thinking of as a palliative care doctor, what I'll be thinking of as an internal medicine hospitalist. And then we'll also talk about some, physiology and pathophysiology and medicine behind why I'm thinking the way I am. We'll talk about pain pathways and some very educational things. And then I'm also going to talk about how to deal with a patient's death. As a palliative care and hospice doctor, I take a lot of patients that are, actively dying or end of life. And this is a very important subject that I feel like is not talked about enough. So we're going to talk about how to deal with the patient's death. And then in the end, I'll give you some pearls on, things you should focus on if you're pre-med and what to look out for and things to help you. And then at the end of it all, I'll just talk about, resources and ways you can reach me if you have any questions. So a little bit about me. I am an internal medicine hospitalist. So a hospitalist is a doctor that manages patients that are admitted into the hospital. So what happens is like patients go to the emergency room. Let's say someone goes to the emergency room with chest pain. That's the ER doctor who sees the patients. And then the ER doctor might say, this might look like it's cardiac in nature and we need a further workup. And then they call me, the hospitalist, to come see the patient in the ER. And then I admit the patient into the hospital. So I'm the doctor that follows the patients that are admitted into the hospital from start to finish. So when it's COVID patients, COVID patients come to the ER, and if they're sick enough to need hospitalization, I'm the one that admits them and follows them from start to finish till when they're discharged. So, a hospitalist is someone that does very nitty-gritty internal medicine, admitting patients to the hospital. We also coordinate care with other specialists. So let's say if that patient is coming in with chest pain, I will be the doctor that coordinates the care with the cardiologist. I call them in to discuss the case and I tell them, this patient's here with chest pain. It looks like he might need a cardiac cath or a procedure. The cardiologist then comes and sees the patient, and then both of us manage the patients together. So whether it's the cardiologist or the lung doctor, you're kind of like the pivotal point and a point of contact for all the specialists. That's if I had to describe it to, related to one show on TV, an internal medicine hospitalist is like Dr. House. When a patient's admitted, you're thinking of ways like, okay, what's going on with this patient? What could be wrong? And you're coordinating care with different specialists, whether it's oncologist or pulmonary doctor. So it's really fun. And the reason I chose is because you kind of get to do a little bit of everything. You get to do the nitty gritty medicine. You're thinking of all these differential diagnoses. You get to work with other specialists. Most internal hospitalists also have a 7-on, 7-off schedule, which means we work 12-hour shifts, 7 days straight, and then we get 7 days off. So that's also very appealing to some people that kind of, don't want to work every day, but, the days you're working, those 12 and a half hours, kind of like ER shift, it's heavy work. So you're not really able to do anything when you're working that week. And it's also, inpatient medicine, not outpatient. So a lot of primary care doctors do outpatient medicine, but I enjoy inpatient medicine because it's more acute cases. And then I'm also a palliative care and hospice doctor, and I'll talk about what that is. I went to UT Austin for my undergrad. I did medical school at Touro College in New York City. I did my residency in Brooklyn, New York, and I did my palliative care fellowship at NYU. I am a locums doctor. So a locums doctor is, there's how there's travel nurses, there's also traveling doctors. So what I do is I go to different areas of the United States where there's shortage of doctors. So I live in New York City, but 1 to 2 weeks out of the month, I travel to these areas where there's a shortage of doctors and work at these facilities or hospitals. During COVID, I have been working at pop-up facilities or field hospitals. New York City became, the epicenter of the pandemic, and there was a severe shortage of doctors here. So throughout the pandemic, I have been at what we call pop-up facilities, which means, all these tents that you see that were erected in Central Park. I was working at this, makeshift hospital on Roosevelt Island, which is like this island between Manhattan and Brooklyn. And then for the past month and a half, because I'm a locum doctor, the government hired me to travel to different areas of the country where there's a surge of cases. So last month, I actually just got back about 4 days ago. I was in West Texas working at a convention center there. So, part of being a locum doctor is that you have to be able to kind of put yourself in work site environments where there's very limited resources. So it's definitely not for everyone. A lot of doctors that work with me at these convention centers and at these pop-up sites are also some doctors that, work in other countries like Iraq and Iran, and like go to these like war-ridden areas and are able to practice there with limited resources. So it's definitely been a great learning experience working with these incredible doctors and learning how to practice medicine with very limited resources. But it's obviously not for everyone. It's for someone that likes to be able to do that. And then I also do some media contribution. I regularly write articles discussing COVID or vaccines or how COVID impacts the health, and just doing some public education from magazines. I contribute to news outlets and podcasts and articles, just kind of raising public awareness of what's going on and just medicine in general. And then there's also preventative medicine that I think is a very important topic that I sometimes focus on, and finding ways to prevent, and this is mostly for the, the public or the masses, finding ways to prevent blood pressure or prevent diabetes, and talking about ways you can be eating healthy, and just doing some education regarding that. So that's a little bit about me. So now let's just hop onto the case. So let me minimize this. So I can see the screen. Okay, so the case, Mrs. Smith is a 45-year-old female with stage 4 metastatic breast cancer. This might be a heavy topic for some people. So if it is, and if you want to excuse yourself, that's completely fine. It's not for everyone, but we will be talking about palliative care and hospice and dealing with the patient's death. So this is a heavy case, and this is a real life case. So Mrs. Smith is a 45-year-old female with stage 4 metastatic breast cancer. She's admitted to the hospital with severe pain in her hip, lower extremities, and upper extremities due to bone metastasis. Her disease has progressed and she is more tired with decreased ambulation. She follows with oncology clinic regularly and is currently not a candidate for chemotherapy due to progression of her disease. You are consulted for pain management and goals of care. A little bit of social history about this patient. She is married with 3 children. She used to work as a biology teacher in high school, and she is very involved in her church and community. So recap, she's this 45-year-old female with metastatic stage 4 breast cancer. She came into the emergency room because of severe pain, and you are consulted for pain management. Oncology sees her and she's no longer a candidate for chemo. And this is a typical case that we usually see as like a palliative care physician. So what is palliative care? So palliative care is a field of medicine that focuses on anyone with a serious chronic illness. So palliative care and hospice are 2 different fields under the same umbrella. So palliative care is for anyone with a chronic illness, whether it is end-stage renal disease, end-stage lung disease, heart disease, cancer, dementia. And the goal of palliative care is to provide relief of symptoms or stress along with providing support. So we do a lot of pain management. We are trained to use very high dose opioids, but not just opioid medication, even other pain modulations to manage patients' care, whether it is cancer pain or pain related to, manifestation of another disease. And then we also provide support to patients and families, and that's a very big part of what we do. We work in a multidisciplinary team approach. So it's not just the palliative care doctor, but I also work with nurse practitioners, social workers, chaplains to address patients' physical, emotional, and spiritual need. So it's a whole like mind, body, and soul approach when we're seeing the patient. It's appropriate at any age and at any stage of the serious illness, and it can be provided along with curative treatment. So it could be for anyone, even if there's a cancer patient with stage 2, breast cancer, and she's getting chemotherapy and she's improving, but she might be having some pain. So a lot of what we do is pain and symptom management. Hospice, on the other hand, is for anyone that has a life expectancy of 6 months or less. So palliative care on one side is for anyone with a serious chronic illness. Hospice is for 6 months or less. People often think of hospice as a place, but it's actually a service that is provided. So it's not a place. Hospice can be anywhere. It could be in patient's home, which is ideal. A lot of patients, when they have less than 6 months to live, want to die comfortably in their home. It could also be at a nursing home, or it could be inside a hospital. It could be, inpatient hospice, which is where the patient is actively dying and they're admitted into the hospital. The goal of hospice is to provide comfort. And an ideal situation, it would be, the patient dying comfortably at home, surrounded by family. So what I also do as a hospice doctor is I make house calls. So a lot of these patients I see that are on hospice, I visit them at their home. I go into their home, I assess them because a lot of them are too weak to go to the hospital or take a Uber or a cab to see a doctor. So I visit them at their home and I assess their symptoms. So as a hospice doctor, you have to be very good at practicing medicine in general, because you're seeing these patients at home, you're trying to assess, is their heart failure acting up, or are they having difficulty breathing, what is going on? And there's no imaging technology with you, there's no x-rays, there's nothing. So you have to be very good at certain general medicine skills that you actually learn in medical school. And seeing these patients at home, it's a very, it's a very private and intimate moment. And it's actually an honor to be able to do that. So again, we work in an interdisciplinary team approach. So it's not just me on the palliative care and hospice team. I'm with a nurse practitioner, a social worker, chaplain, a therapist, grief counselor, and they each have their own very specific role. So when we go in to see the patient, I as a doctor have to assess, okay, what is it that, a chaplain can do for this patient? What is it a social worker can do? And we'll talk about that. So an approach to palliative care and hospice, again, we do a mind, body, and soul approach. We manage their pain and any other symptoms the patient might be having, but we also address the psychosocial aspect of it. When someone is in pain, you're not just looking at the patient, you have to look at the human as a whole. So, what is it about this patient that makes her human? She has children, she has a family. So when I'm thinking of her children and I'm thinking of her family, thinking of the fact that she's no longer going to be on chemotherapy, I'm thinking of ways a social worker could be helping this patient. Social worker can help in ways to provide, some therapy to the children or talk to the family if they want to talk to the children about what's going on. The religious aspect of it, she regularly goes to a church, and for me to not address that aspect of her that's a very big part of her life is kind of denying her humanness. So I would ask my chaplain to come see her and see, is there any way he can contribute in finding ways to maybe, do last rites or talk to, any religious leader that she might want us to speak with. So again, we're looking at a patient as a whole, and that is one of the best reasons I really enjoy practicing palliative care, because you're not just, compartmentalizing them, you're looking at the entire person. So again, the case, 45-year-old female with metastatic breast cancer, came in because of pain in her hip and lower extremities. Oncology, she follows with oncology. They haven't told her that she's not a candidate for chemotherapy. You're consulted for pain management. So now let's talk about the pain aspect of thing, okay? So when I see this patient as a physician in the emergency room, or she's admitted into the hospital, and they're telling me that she's in intense pain, what's going through my head is that what type of pain is this patient having? Now, I know that in her case, she is complaining of hip pain, and she's complaining of pain in her lower extremities and upper extremities, and she has breast cancer. So the first thing I'm most likely thinking of is that this is likely metastasis. This is likely related to her metastasis. So there's different types of pain. When someone comes in with pain, we don't just think one thing. We have to get a thorough history on what is it that's going on. So the pain history is PQRST. So it's like quality, pain, severity, what makes it better, what makes it worse. Is there anything that she took medication-wise before she came in that made it better? Is there anything that made it worse? So there are different types of pain. There's somatic pain, which is the pain that occurs when there is, where the receptors in the tissue are damaged. This is typically occurring when there's force, temperature, vibration, swelling. For example, if someone, burns themselves, it's usually described as cramping and gnawing. So getting a pain history is so important. There's also nociceptive pain, which is a general term used to describe any physical damage or damage to the body. And that might be felt when there's a sport injury, dental injury, arthritis. There's also neuropathic pain, and there's different medications we use to treat each of these type of pains. So a neuropathic pain is when there is when there's injury to the nerves within the system. So the best way to describe this is when there is burning and tingling caused by nerve pain. Diabetic nerve pain is usually described as, it's just a burning type pain. And that's very different than the somatic and nociceptive type of pain. So it all is very dependent on the type of history we take. So in this case, she's complaining of the way she describes it is that, it's in her upper extremity, lower extremity, and is likely related to metastasis. So what I would say this pain is a somatic nociceptive bone pain. And the treatment I would use for her if the general Tylenol doesn't work is opioids. So as a palliative care doctor, we're very well versed, and a hospice doctor, in using opioids for pain management. Now, opioids get a very bad rep because there's obviously a potential for abuse. But if opioids are created for any type of patient population, it is the palliative care and hospice population. Because, our goal is always to make sure the patient is not suffering in pain. So there are definitely a lot of type of opioids that are out there. There's morphine, oxycodone, Dilaudid, and we choose which opioid to use based on the patient's kidney function, based on the patient's liver function. For example, if someone has severe kidney failure, I would not be using morphine. I would likely be using something like Dilaudid. So, I would be reviewing this patient's chart to see, how her kidney function is, how her liver function is. Has she used these medications before? And with opioids, the one thing I would be prescribing is stool softeners. Opioids are notorious for causing constipation. And if a severe constipation is untreated, it can actually lead to bowel obstruction. So in her case, I would be prescribing, either morphine or Dilaudid or oxycodone based on her liver function or kidney function, and some stool softeners with it. Common side effects of opioids are nausea, vomiting, constipation. And, for her, if it is a single lesion of bone pain, so if she was just describing bone pain in her hip, then I would also consider, radiation to that area. So it's really dependent on the patient's history and the type of pain she has. So that would be the pain aspect of it. And then the psychosocial aspect of it is that, she has 3 children. So, and she's currently married. So again, you always want to look at the patient as a whole. So providing support to her and her family would also be a big part of what I do. I want to make sure she knows that we are here for her, and what she's going through is not easy. And I want to find ways to be able to support her and her family. She's also a biology teacher. This is a big part of who she is and what she does. And then I would also make sure to get my social worker involved to see if there's ways we can, manage any social aspect, whether it is she needs help with contacting, her school or her work regarding her not being able to work anymore, or us talking to her children about what's going on and getting a licensed, child therapist involved, whatever it is that the patient needs. I want to be able to handle all aspects of her care and not just, the pain management aspect of it. And then the spiritual aspect of her, she is Christian. And, in the case, we talked about how faith is a big part of her being. So I would also get our palliative care chaplain involved, who, see patients from all different religious backgrounds. And these are usually palliative care board certified chaplains. So they are well versed in different religions. And their goal is also to contact, leaders in the community. Let's say if the patient is, whether the patient is Muslim or Hindu or, Jewish, whatever the patient needs, the palliative care chaplain can contact leaders from the community from that specific background and be able to help the patient. So now let's talk about the patient. We talked about how she is not a candidate for chemotherapy anymore. And so the oncologist would be contacting me and letting me know that, hey, we have to tell this patient that she's no longer going to receive chemotherapy. And that is obviously a very bad news that you have to be breaking to the patient. And a lot of my job as a palliative care doctor is breaking bad news. And so what do I do when I see this patient and I have to tell them that, hey, you are no longer going to be a candidate for chemotherapy? I just don't walk into a patient's room and straight up tell them that, oh, we're not going to be doing chemotherapy anymore. That's not how it always works. So what actually happens is that there is a process I use that we're trained to use to be able to properly communicate to this patient about what is happening regarding their care. I would be getting in contact with the oncologist, and then, I would be telling the oncologist, hey, let's sit down together, get a detailed history from him about why she is no longer a candidate for chemotherapy. And where did the presentation go? Sorry about that. Why she's not a candidate for chemotherapy. And then I would sit down with her and go through a certain process. I just wanted to kind of give you an insight on what I would be doing. So first, what we use, it's called the SPIKES protocol. And S stands for setting. So first I would be setting up the interview. I would want to make sure that while I'm trying to break this bad news to her when she's admitted to the hospital, there's not Jerry Springer going on in the background on the TV. I want to set up for a really nice interview where I'm able to properly explain to her about what's going on. So I would, I walk into the room, I make sure that there's no TV on, no loud noises, there's enough seat for all the family members to sit. Because usually these meetings happen with the family members, the patient, the oncologist, the hospitalist, anyone that's involved in patient care. And then what I do is P is for perception. So I would ask the patient, what is your understanding of what is going on with your cancer? So in this case, the patient would say, I know I have stage 4 breast cancer that has metastasized and I have pain in my hip, and that's why I'm admitted to the hospital. And then I would ask her, what is your understanding of what the oncologist has told you regarding your treatment? And then she would say, currently I'm on chemotherapy, but I don't know my plan going forward. And then I is for invitation. And then I would ask her, how does your family want to hear the information? So first I would ask her, do you want to hear information regarding your care, regarding chemotherapy going forward? Because this step is to be mindful of different cultures. So in certain cultures, for example, in certain Asian cultures, that I've had patients tell me that, what, I don't want to hear anything about my treatment and care. Talk to my eldest son, or talk to, my family. I don't want to be involved in my care. And that's completely fine. This is the patient's decision to make. And our job is to just be there and be supportive and be mindful of their decisions. So, in this case, a patient would say, yes, tell me what my plan is going forward. And then K is for knowledge. And then I would share to her about what is going on, that I would tell her that, the oncologist and I have reviewed all your medical records, and the oncologist most likely would be the one sharing this information that we are no longer going to be offering you chemotherapy. And then after that, I would assess the emotional response. At this point, I feel like this is the most important step. I want to be able to make sure that I tell the patients that I'm going to be here for them no matter what. Just because she's not getting chemotherapy does not mean that we will not be taking care of her. We will be making sure that her symptoms are managed. We're going to be making sure that we're here for you and your family no matter what. And we're going to offer support no matter what. And then in the end, you just want to summarize again, like, okay, can you just summarize for me about what we just discussed? So that's how I usually go on breaking bad news. The other aspect is goals of care. So now the patient is no longer a candidate for chemotherapy. What are her goals and wishes? Would she want CPR if her heart stops, knowing that she has this metastatic cancer, or would she want to go naturally? Would she want a trial of intubation? Some patients say, do the CPR, but don't do it for too long, or some patients would say, yes, I want to be intubated, which means, put on a breathing machine, but I don't want to be intubated for a long time. You know, if my quality of life is not going to be what it was before, then I wouldn't want this. I don't want to be in a vegetative state. So this is where we kind of try to assess what is it that the patient wants. So based on what their goals and wishes are, we're able to give recommendations and also document what their wishes are. You know, in the end, you never want to do something the patient wouldn't want. If someone is 100 years old and they've said that they want to go naturally, then it's our job to make sure that that's what happens and they're not getting CPR. So it's in the end, it's all dependent on what the patient wants. Our job is not to convince them one way or the other, but just to talk about these things openly, because these are tough conversations to have. And then, you know, in this case, the patient, after the conversation, goals of care conversation, she decided she wants to be DNR, and die naturally. So now we're going to talk about how to deal with the patient's death and what happens when someone actually dies on the floor. This is obviously a tough topic, but it's important to discuss, because even if you choose nursing or PA or NP or any specialty in medicine you choose, you will at one point deal with the patient's death or see it. So it's important to kind of discuss, you know, what happens and walk you through things that we do. So you are a resident on call and you are notified that this patient, Mrs. Smith, has died at 2 a.m. You are called to pronounce her and do a death exam. So prior to you going into the room and doing a death exam, let's pretend that you don't really know who this patient is and you're just a resident on call. And so you want to make sure that you are checking the patient's chart. You want to make sure that you're checking the patient's resuscitation status. So you want to make sure she's DNR, DNI in this case. She is, let's say if she's full code, which means that, you know, she wants CPR. So you would go ahead and do CPR. But let's just focus on this case. So in this case, she does not want CPR. You want to make sure you're reviewing the patient's note before going into the room and knowing what she's in for. You know, you want to know a little bit about her medical history, because when you are the doctor in the room, you have to be a little bit versed on, you know, why she's admitted. So in her case, it would be because she has breast cancer, she was having pain, and that's why she was admitted. You want to clarify the circumstances surrounding the death. And you know, you know, any information that is documented in the patient's chart that's flagged, you want to make sure that you're reviewing all of it. Before, if the family and friends are present, when you're asked to come in to do the death exam, you want to make sure you're introducing yourself and offering your condolences. You know, you want to make sure you're being empathetic and you know, make sure that you're conveying to the family that you're seeing a loss and you're feeling for them, and I know this must not be easy for them. And then also, you know, check with the family if they have any questions or concerns. So what does a death exam entail? So when you're walking into a patient's room and performing a death exam, there's a few things that go in. First, you know, you always want to make sure, especially in the time of COVID, you have your PPE on. You want to wash your hands, make sure you're gloved. You walk into the patient's room and then you're making sure that it's the right patient. You always want to check their wristband. You want to make sure you're not doing a death exam on the wrong patient. You want to observe any sign of life, such as movement or respiratory effort. You want to verbally call this patient. You want to say, hello, Mrs. Smith, can you hear me? Assess any painful response. You assess their pupillary reflex by a pen torch. Pupils often become fixed and dilated when patient has died. You want to palpate their carotid pulse. You want to make sure it's absent. You perform auscultation of the heart to make sure that, you know, nothing is beating. And then, you know, in ICU settings, if we're trying to assess brain death and all that, there's apnea tests and there's all these things that you would learn about. So death is a normal part of life, but doesn't mean it's any easier. Seeing a patient die is something everyone, whether you're a medical student, resident, nurse, physician, any other medical provider, will experience during their careers. You want to be able to express emotions. If you were close to this patient, let's say you've been following this patient for quite a while, you want to let yourself feel the loss. You want to express your feelings and openly talk to your colleagues and, you know, explain to them like, hey, I really got close to this patient. I've been following her for months. She has children, she was married, she was so young. It was so hard for me to see this patient die. And you want to be able to talk about these things openly, because you don't want to keep this pent up. If it starts impacting you negatively, that's going to impact your future patients. So you want to make sure you're able to express these emotions. And when you are in residency, when you are in medical schools, you're going to be along your colleagues. And one thing you'll notice is that these colleagues will become your close friends, and the reason you'll become close to them is because you'll be sharing similar experiences in medicine. And medicine is not glamorous all the time. It's you're dealing with human lives, and you're dealing with human loss, and it's okay to feel emotions. It's okay to talk about things openly, and it's not easy. You also want to take some time to reflect. Everyone deals with patients' loss in their own way. Take time to reflect about what you just saw, what you just went through. I would say from a personal experience, working at these pop-up facilities for COVID patients, and throughout the pandemic, the hardest thing for me, even as a palliative care doc, is seeing the amount of patients that have died, to see the sheer volume of patients that died and how they were not able to be with their loved ones when they died was very difficult for me. And it's something I talk about, very openly with my partner, my friends, and my colleagues, my parents, and I talk to them about how that's probably been the most difficult part about doing what I do during this time, seeing so many patients die, and it's not easy. One of the book recommendations I have is Atul Gawande's Being Mortal. This is a great book that touches on this topic of death and dying, and dealing with a patient's death. And I feel like if you are going to be pursuing medicine, you don't want to just read biology textbooks. You also want to read about books that touch on the human side of medicine, and human side of what we do. Dispel any feelings of failure. You can't control if someone gets metastatic cancer or another chronic illness. As a doctor or any other field in medicine, you will be doing the best you can to help these patients. But if someone dies, you want to make sure you're not blaming yourself for it, because death is a part of life, and it happens to everyone. It's going to happen to me. It's going to eventually happen to you, and it's going to happen to everyone we love. So, that the patient dying has nothing to do with you as a person, and it's not a failure on your part. If things get harder, speak to a licensed therapist. It's important to realize when patient's death is starting to impact your mental health. You're unable to sleep, you're unable to eat, you are unable to focus, you are very pre-consumed with this patient's death, and it's impacting you in a negative way. It's really, really important to ask for help. This is the most important thing you can do, because asking and helping yourself will also help your future patients going forward. Okay, so now I know that was like a tough topic. It's not easy always to talk about patients' death and dying, and this is a tough topic, and I really commend all of you for listening through all of that. It's a heavy subject, but I think it's a very important subject to talk about, and that's not being talked about enough. So now I'm just like some advice for medical school. An advice I received that I felt like bode very well for me was, you have to get a mentor or shadow doctors. You truly don't know if you want to pursue a certain field in medicine, or if you like a certain field, till you actually do it. So one great thing about when you are in medical school is that you'll do all these different rotations. And when you do these rotations, you want to make sure that you keep a very open mind. I went into medicine thinking, oh, maybe I would want to do OB-GYN, and I did my OB-GYN rotation, and I was like, nope, I don't want to do this. A lot of my colleagues went into medicine thinking, oh, they want to do internal medicine, and then they did their surgery rotation and fell in love with doing surgery. When you'll rotate through different specialties, you'll find yourself like, oh, okay, maybe I like outpatient medicine better. Maybe I like dermatology better. Maybe, I don't like practicing this nitty gritty internal medicine. Maybe I want to do more procedure heavy, or I want to combine. In my case, you know, when I was shadowing all these doctors, I realized that I liked doing inpatient medicine. I liked traveling, I liked giving back, and this is what I enjoyed, and this is what I did not enjoy. So make sure you keep an open mind. And if you're thinking about a specialty, make sure you shadow that doctor, because you might end up shadowing that doctor and realize it's actually not something you want to pursue. Volunteer, you know, that's definitely an important advice I would give everyone, pursue all pre-med students. People go into medicine to help people. And, you know, I know it's like a very mundane question everyone gets asked: why do you want to choose medicine? And most people will tell you, most doctors will tell you that they went into medicine to help people. So you want to show that you're willing to help people by volunteering, because that's a great way of showing that you are selfless and you like to do things for other humans and not get paid. And then, you know, study early, apply early. I was that person that applied right when the medical school portal opened up. I made sure that all my recommendations, you're actually able to upload a lot of your recommendation letters, your personal statement. You're allowed to upload that even before the application can be submitted. So when that portal opens up for you to submit your application, you want to be the first application they see, because, you know, once they review enough applicants, you know, they might not look at your application if you were the last person to submit it. So you want to make sure that you're on top of it and you have all your letters of recommendations in early on. And then get involved in extracurricular activities, you know, not just medicine, but pursuing other things that you feel like, you know, are interesting, and it's something that truly just brings you happiness, whether it is music or other clubs and other activities or other social clubs, anything that you feel like, you know, that add to you and add to you as a human in a positive way. And then most importantly, I think the best advice that has given to me and that I always give to people is be humble, and be kind. You know, people love doctors that are just genuinely good human beings. So you want to be that doctor that's just overall a kind, humble soul. You know, you want to be, you know, medicine is truly an incredible field, and you want to go into it for the right reasons. You truly want to go into it to help people, and to make this world a better place. You know, if you go into it for the wrong reasons, like for the money, there's not much money in here. You probably want to do investment banking or something like that. But just to, you know, I went into medicine because I absolutely love science and I loved helping people. And overall, you just want to be a good human, you know? And then that's it. So do you guys have any questions?
Yep, we have a lot from the audience here.
Okay.
They're captivated by your presentation. First and foremost, we want to thank you for all the work you've been doing on the front lines of COVID. It's really appreciated, and yeah, very
Thank you.
awesome that you do. The first question we got is, how do you manage being a locus physician, working 7 days in, 7 days off, and balancing that with your family and social life? How does traveling also factor into that?
Yeah. So, you know, COVID has been a very intense time for all doctors that are hospitalists or ER doctors or any of those fields that are seeing patients firsthand. So I would not say that this is my regular schedule. When I'm on these assignments, I'm usually working 12 and a half hours, you know, sometimes a month straight with 1 day off every 7 to 8 days. But that's not usually my schedule. My usual schedule is 7 on, 7 off. And then on my time off, I do palliative care. So when you have that 7 off schedule, when you have those 7 days off, you know, that's when I try to do, you know, fit in all the time with my family and friends. And that's how like a lot of ER doctors work in their schedule too. You know, a lot of medicine is either you're doing clinic work, which is 9 to 5, or you're doing the shift work. So the shift work is always like the 12-hour shifts. And that to me works better for me because I like just knocking out my work and then having that time off. Then 7 days you can travel. Sometimes you're able to combine your shifts. So as a locum doctor, it gives me flexibility. So sometimes I combine like my 13 or 14 shifts together, and, work all that time. And then I have like 2 to 3 weeks off. So if I ever want to do international travel, it allows me to do that. So it's always just like there's ways of finding balance, when you're actually doing it, you find ways to find a balance, so I absolutely love traveling internationally. And so that's why locums works for me, because I can combine my schedule and have a lot more time off.
Definitely. You obviously love traveling, and traveling requires a lot of adaptability, and especially being a doctor, like you said, you have very limited resources sometimes. How do you adapt to such as complex and variable issues you treat with not that many resources and a different environment, and balancing all that together?
Yeah, I think that's definitely one of the hardest parts. And that's why being a locum doctor or a traveling doctor is not for everyone, because you have to be willing to adapt to new hospital systems, new electronic medical records. During COVID, have to adapt to learn, treating patients with very limited resources at these convention centers or pop-up facilities. But it's something you learn, when you go through residency, when you go through your fellowship, and when you start practicing medicine, you acquire a set of skills that allows you to practice like this. And if you do it enough, you start getting good at it. So the reason the government hires me to go to these areas is because I've been working at these pop-up facilities for about almost a year now, and I know, what we're capable of handling at these facilities, what we're able to treat, what we're not able to treat, what patients needs hospitalization, what patient we could treat at these facilities. So it's just a skill set you develop, and like everything, the more you do it, the more you practice it, the better you get at it.
Definitely, definitely. You also mentioned during your presentation that you have to be knowledgeable about the mind, body, and soul, a more holistic approach to medicine. So, how does being a DO make your approach to hospice care different than, let's say, like an MD's approach?
Yeah, so I think both approach are similar, but I would say that my DO training was basically, a lot of it was based on the whole mind, body, and soul approach. So it's definitely something I carried in to my specialty. And there's similarities that you find in your training and what you're doing now in your specialty. And that's definitely something that got carried over. But I would say this approach is something that should be practiced by all doctors, MDs and DOs, because it's very important to treat the patient as a whole and not just compartmentalize certain aspect of their care. Because the more you practice medicine, the more you'll see that, the pain, for example, it's not just physical pain, it could be emotional pain, it could be psychological pain. There's just so much that's going on. And it's your job as a doctor to do your due diligence and look at the patient as a whole, and not just be like a robot and focus on one aspect of the pain.
Definitely. On the same track, how is to your knowledge, your path to becoming a DO different than would it be if you were taking an MD path? And why did you choose the DO path instead?
So when I was applying to medical school, I went to UT Austin, and I applied to a lot of schools, MD schools in Texas, and I was applying to a lot of MD and DO schools in Texas and, in other parts of the country. And when I interviewed in New York City at my school, Toro College, which was based in Manhattan, during my interview, I actually shadowed a DO doctor who was a dermatologist actually in Texas. And I just saw the way he was, handling patients and his method of care. And he told me to look into both schools, which is something I recommend. And I picked my particular school because of, one, the location. I wanted to be in New York City. I knew that the training I would get being in New York City would be so different than any other state, just because of the pathology of cases you see here. and New York City is also a fun city. So, when I interviewed at the DO school here, I liked it better than the MD school in Texas. And I think a big part of me just wanted to move out of state. So that was one of the reasons I chose it. And I really liked the whole mind, body, and soul approach. When I was comparing the two, I didn't feel like there was any, there's not much difference, except the DO school has more of the osteopathic medicine component. So there's a little bit more focus on, how the osteopathic medicine part of it, which is, body, like the way the body works and how everything is more connected, and focus on a lot more anatomy aspect of things. Which was always a plus, but in the end, it's all the same. And so you should pick a school where you feel like is which you feel like is a good fit for you, MD or DO.
Definitely. On the same line, especially your focus, it's so holistic in terms of the people you're working with and very emotionally demanding. How do you keep your empathy and stop from being desensitized with dealing with death? And how do you separate that from your personal life?
Yeah, so I don't think, seeing people die is ever something you just get used to. It just doesn't happen. You every time you see a patient, you realize that this patient is a human being with their own family and own friends, its own, their own goals and wishes and things they want to do. And it's not something you ever get used to, but you find healthy ways to cope with it, So, I do a lot of mindfulness. I'm a very social person, so I make sure to make time for, time to hang out with my friends and hang out with my partner, and make sure I'm spending time with him and spending time with my family and connecting with them. So, you want to make sure that you're doing things that bring you happiness. And then you just kind of find ways to, I would say, compartmentalize, although that's not a good word in this situation, but you kind of find ways to, kind of separate the two. But you never get desensitized to it. It's something, definitely something I think about. Sometimes I have to struggle with it, but at the same time, I've learned healthy coping mechanisms, you just want to make sure that you have healthy coping mechanism and you're not turning to like drugs and alcohol or something and access.
So you also mentioned your role as a hospitalist as almost like a cog between all these moving parts in the hospital. How do you, one, keep everything organized with multiple patients receiving multiple input from different specialties? How do you keep all that organized?
So you actually find methods to do it. So when you are in internal medicine residency, you will be inpatient. A huge part of your training will be inpatient. So a huge part of your training during internal medicine residency will be when you're going to be on the floor. You're going to be with the internal medicine hospitalist attending that will be with you, that will be seeing patients with you. So a normal day looks like me coming in, I'm giving these patients, a lot of patients you're following from the day they're admitted. So you have a little background of what's going on. You review the patient's chart, you go through all their labs, you go round and see the patient. So you see them individually, and then you contact the specialist, you come up with the plan, you come up with what's going on. So this is something you're trained in, and it's going to be 3 years of you doing this in residency that prepares you to, be a good hospitalist. So, and you do it in residency with supervision. So you're never alone. And so you also have autonomy, but at the same time, you also have backup to kind of ask questions, and you'll be with the senior resident. And there's just so much training that goes into it that really prepares you.
Definitely. And back to COVID and everything that's going on. Obviously, the patients' families aren't there sometimes to break the news to them. So we've been hearing a lot about having to FaceTime family members or things like that. Is telehealth, do you think, compatible with hospice and end-of-life care? Or does the virtual aspect of it lack the sensitivity needed for the specialty?
Yeah, I mean, that's a great question. So a lot of, palliative care consults I've been doing have been through FaceTime, through, iPads that we use. And that's probably been the most heartbreaking part, when someone is dying or if someone is end of life, you want to be able to be there with the family members. And it's been so hard seeing that the family members can't come visit all the time. They're not there to hold the patient's hand. And, I can't even like hold a patient's hand without gloves, so that human aspect of it is missing. And that's definitely the hardest part during this pandemic. And so telehealth has been beneficent, or using the iPad to communicate with patients' families, kind of tell them what's going on, or see if the patient, be able for the family to be able to see the patient on their deathbed, or just communicate certain aspects of their care has been beneficial. So at least we have that technology to assist. But yeah, there's definitely been a disconnect. That's been the hardest part about this pandemic, just the whole loss of humanness to this disease.
Mm-hmm. And COVID has been very disastrous to the state. So again, we're super thankful for all the work you've done. And in your work as a locum doctor, you're traveling a lot. Do you have a home hospital, or do you have a place that you consider home, or
Yeah, so my home's actually New York City. So this is where I live. So as a locum doctor, you have a home. So New York City is my home. There are a lot of I don't travel all the time. During COVID, I have been traveling because I've been hired by the government to travel to certain areas. But most of the time I am in New York City. I work at hospitals in New York City. There's a few hospitals that I rotate through, that I work at, like 1 week here, 1 week there. But if needed, I do at least 1 to 2 weeks out of the month go to these areas. But during COVID, it's just been me going there for like a month or two straight instead of, a week or two, what I would usually do. So you have your base. So, New York City is home. I have my apartment here that I live at. So this is like my base, and this is where I usually work.
And to kind of wrap it up here, as a traveling physician, do you think are the most rewarding experiences, or if you have a particular most rewarding experience that you have? And on the same note, have you ever been traveling internationally, and how does that differ in terms of American medicine? And
no, so the most rewarding part is, going to these areas where there is a shortage of doctors and being able to treat patients there. When I was done with fellowship, I wanted to take a year or two off to travel internationally, whether it was South America or Africa, or help out with, the area, help out in different areas in these countries where there's a shortage of doctors. And when I was doing the research, I realized there's so many places in the United States itself where there's a severe shortage of doctors. So, usually I go to places like Missouri, like Ozark, Missouri, or, even upstate New York itself. When people think of New York, they think of New York City, but actually, upstate New York, close to Canada borders. Also, there are some rural areas where there are not that many doctors. So there are a lot of places in the United States itself that has shortage of doctors. So that's definitely been the most rewarding part, being able to go to these areas and realizing that the healthcare is not the best. And there are also some challenges because, there are times it's difficult traveling and being away from family and friends. When it comes to international travel, the thing about traveling, nationally, just in US, is that every time you go to a different state, you have to get a license for that state. And so with the international travel, the difficult part is, transferring your medical license and things there. So there's obviously Doctors Without Borders. There are all these organizations you can work with that kind of help you with that transition, help you make sure all the paperwork is in order so you are able to practice in other countries. But there's also a lot that goes into play with the whole licensure and what you're covered for and what you're not covered for, how the malpractice goes into play. So I would say it's definitely easier to do it just nationally than internationally.
Definitely. I just want to thank you for the presentation today. I know I learned a lot, and I'm sure our audience learned a lot too.
Thank you. I know this was a heavy topic, but I do think it's an important topic. If you have any questions, I do my best try to answer any questions I have when people reach me through my Instagram. So it's Dr.Lalani, so Dr.Lalani. If you have any further questions, feel free to contact me and message me through there. I will try my best to answer it. But I wish you guys all of luck, and I hope everyone stays safe.
Thank you again. And for our audience, we're going to drop our quiz link in the chat right now. Please make sure you take your time on those questions, really reflect on Dr. Lalani said today so you can get the most out of the experience. It's time sensitive, so make sure to do it as fast as you can or whenever you can. And I want to thank you all for coming, and make sure to come out to our next meeting this Thursday at 5 p.m. All right, see you guys.